Hi, my name is Heidi Steiner. I'm currently a graduate student at Weldon University, and my practicum experience has been focused on informatics concepts within nursing education. And I've spent some time here at Rochester College, and also I've spent time at Oakland University these past 12 weeks. And I have a presentation for you today that will talk about how we can incorporate technology into the care of the patient. When I was preparing for this presentation, I had not yet come up with a title for my PowerPoint presentation. And I called our Director of Nursing, Kathleen Van Wagner, and asked for her input. She wanted me to somehow incorporate the caring aspect into my presentation because we hear so many times that the nurses spend too much time in the computer and not with their patients. And we're trying at Crittenton Hospital to incorporate caring behaviors into the patient care utilizing technology as a tool. So with that in mind, I went back to our relationship-based care journey that we've been embarking for the past several years and came up with the title, Using Technology to Care Through a New Lens. The picture you see here was developed by our nursing leadership team at Crittenton Hospital because we have embraced the journey of relationship-based care to focus on our patients while we as the center of our care team at Crittenton. So with that, the objectives for today are to define nursing informatics, summarize the 6 quality and safety education for nurses, or QSIN competencies, and I'll talk about that in a minute, differentiate between computer skills and informatics competencies, because they're two very different things, describe how informatics can help progress data to wisdom, identify ways to use the EMR to integrate the following informatics concepts into a clinical simulation. We want to talk about a decision support rule, evidence-based practice, a reminder to provide imperative data, data mining, and interdisciplinary care plan. And you'll see all those in the scenario that we'll provide following this presentation. What is nursing informatics? Nursing informatics is sort of a hard thing to define. Early definitions focus more on the technological part of it. So in 1989, Graves and Cochran defined it as a combination of computer science, information science, and nursing science designed to assist in the management and processing of nursing data, information, and knowledge to support the practice of nursing and delivery of nursing care, which is very wordy. I like Roy Simpson definition that it's a moving target. That's a lot simpler, and a lot of these concepts are what nursing informatics is about, but it is a moving target and it's still moving, and it will probably move for several years to come. In 2008, however, the American Nurses Association defined it as integrating nursing science, computer science, and information science to manage and communicate data, information, knowledge, and wisdom in nursing practice. Facilitates the integration of data, information, knowledge, and wisdom to support patients, nurses, and other providers in their decision-making in all roles and settings, accomplished through the use of information structure, information processes, and information technology. That is the current definition according to the ANA. In 2003, the Institute of Medicine published a report, Health Professionals Education, A Bridge to Quality, and it challenged nursing educators to redesign curriculum based on the following competency areas: patient-centered care, interdisciplinary teams, evidence-based practice, quality improvement, safety, and informatics. And from these came the definition from nursing leaders, which led to the QSIN competencies. I'm not going to read all these definitions to you, but these are the QSIN competencies that we are focusing on, or that they wanted us to focus on for education. But the key point is we have patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. There used to be 5. Informatics was always one of them, and then they added safety, I think, a little bit later. But the key point that I want to make here on this slide is that informatics is needed for all the rest of them. There is informatics concept woven in all 5 of the above QSIN competencies. And the QSIN competencies What they are telling us is that there are specific knowledge, skills, and attitudes that will help nurses prepare for safety and quality in the workplace. And I'm going to do a simulation scenario for you today. And the reason we're doing a simulation scenario is because it has been a way to interactively learn, and it lets the nurse practice in a very safe environment. This is considered a low-tech simulation that we're going to do for you today, but there are several other options for simulation that you can use in the classroom to incorporate informatics concepts into your nursing curriculum. Nurses today are expected to do a lot of things. They're expected to work and partner with patients and families, communicate effectively, use strategies such as SBAR, background and teaching, and ensure patients are receiving care based on specific evidence. Informatics can be used to help with all those different expectations for the new nurse. Sometimes I've heard over the years, and I've been doing this since 2005, that the younger nurses today already know how to use technology, so they don't really need informatics classes in their nursing education. This is not true, because utilizing the computer is not using informatics. The computer is a tool. It's what we get out of the computer that helps us keep the patients safe. It's the things we can utilize the computer for when we're planning care for our patient. And the scenario that we're going to go through in just a minute will show you a couple ways that you can use these informatics concepts just with one patient scenario. The computer helps us convert data to wisdom. These are all little pieces of data. Female is something we put in the computer. Years, 45, regular, pulse, 72. Those are all things we might click on in the computer. What do we do with that? We synthesize that to come up with some information. And then we combine that with some of our past experience and knowledge, and we find that the pulse is normal for a woman who's 45 and of that age, woman and female. And then that combines with our years of experience to tell us that there's no nursing action required. Everything looks good for that woman's pulse or that patient's pulse. So the computer helps take all these data points, synthesize it together, and then we pull it out to make the best decisions for our patient. That's a very simple example of that. So now what I'd like you to do is watch the following scenario, and there's a handout you can follow, and what I'm looking for is ways that we use the computer for decision support rule, and you'll see that in the scenario, and we'll talk about that afterwards. How do we use it for evidence-based practice? How do we remind the nurse of imperative data? How do we use the computer to pull data out, or data mining? And then what do we do with our interdisciplinary care plans to help us focus care on the patient?
Hi, Ms. Chase. I'm Cheryl. I'm going to be your nurse this afternoon.
Nice to meet you.
Nice to meet you. I received handoff communication from your nurse in the emergency room, and they told me that you were admitted for abdominal pain.
Yes, my stomach was really hurting last night.
Okay.
It was getting worse and worse, and when I had a bowel movement, there was blood in it.
Oh my goodness. I'm assuming they told me they took some labs down in the ED.
Yeah.
Okay, so just want to verify your hemoglobin's okay, because that's something that we get concerned about when you lose blood.
I've been very tired too, so tired for so long and really thirsty. I just can't get enough water.
Now, they did tell me down in the ED that you did have a very high blood sugar, and so there's a concern that you might be diabetic, and you're going to learn more about that while you're here. Matter of fact, we are going to need to check your blood sugar again soon. I can see that on my intervention list that we do need to recheck your blood sugar. What we're going to do is, let's talk a little bit about your history. Now, also, the abdominal pain. They gave you something for pain down in the ED. How are you doing right now?
It's starting to hurt again.
Okay. You know what? Why don't I get you something for pain to get you comfortable, and also
Okay.
we'll just go ahead and recheck your blood sugar so that way we can move forward with gathering this information. Now, they give you Dilaudid down in the ED. Did that work well for you?
I think so, because I did feel better afterwards.
And the only medication that I see you're allergic to on your list here is latex.
Oh. I don't know, I took some, I think they told me one time not to take heparin.
Okay, you know what, we'll talk about that in just a
Okay.
moment, but you've had no problems with any type of Dilaudid pain medications?
No.
Okay, I'll be right back. Mrs. Chase, I just need to verify your armband. Can you tell me what your birth date is?
June 11th, gosh, I'm so confused. I think 62.
Okay, well, that's what I have in your record, so. Okay. What I'm going to be giving you is Dilaudid, and tell me where your pain is exactly.
It's in my stomach,
Okay.
right here.
Right there in the middle, and on a scale of 0 to 10, 10 being the worst pain you ever felt, what would you rate that pain?
It's about a 6.
Okay. And what makes the pain worse?
If I kind of move around, or sometimes even if I'm just laying still in bed, it hurts really bad.
What makes the pain better?
So far, just the medicine.
Just the medicine's been working for you? And do you have any other symptoms along with it? Do you feel nauseous?
No.
Okay. And would you describe it as sharp, aching, stabbing, burning?
It's sharp.
A sharp pain. What is your goal? I know this is a silly question, but on a scale of 0 to 10, where would you be comfortable at? Would you like for us to get you to a 0, or would it be tolerable if you were at a 1 or a 2? You're at a 6 right now.
I think a 2. That would be good.
Okay. So we're going to work towards that goal with you.
Okay.
And now we're going to take a look at your blood sugar. Let's check that. And again, I'm just going to verify your armband and compare your birth date. Going to feel a poke. And we can check that off our list.
Okay.
But let's go ahead and, if you don't mind, there's a few things on your history we need to review. Is that medication starting to take effect
It
for
is.
you? Okay, great. Do you currently drink alcohol?
No.
Okay. Have you ever smoked, or do you smoke currently?
Yes, I did smoke. I just quit.
You did? Okay, and how long did you smoke for?
20.
20 years. Okay, and when did you stop smoking?
8 months ago.
Wonderful. That's a great accomplishment. How's that going for you?
Pretty good. It's hard though.
Good for you. That's a great accomplishment. Okay, so I'm going to indicate here you were a former smoker within the last 12 months. Now I want to go over some information about who all needs to be involved in any education that we provide for you. Who takes care of your medications?
I do.
You do? And what about your doctor's appointments? Who makes those for you?
My husband does that. I work midnight, so he takes care of that during the day when I'm sleeping.
Okay, that's understandable. The doctor's offices are mostly closed, right?
Mm-hmm.
What about meal preparation? Who does that?
He does all the cooking.
Does he? Okay, so we'll want him involved when the dietitian comes to see you to teach you about meal planning.
Okay.
Is there anyone else you want involved in your education?
I don't think so.
Okay. Okay. Now, like I indicated about a dietitian consult, what we can do is we can actually consult the dietitian right here from your history. By me indicating yes under patient qualifies for a dietitian consult, that's going to send a message electronically to the dietitian to pay you a visit. Now it's a little later in the afternoon, so it'll probably be tomorrow that we're going to do
Okay.
that. And they did tell you down in the ED that you were planned for to have a colonoscopy.
Yes.
And that's where they're going to take a scope and they're going to look up into your large intestine and see where that rectal bleeding might have come from. Did the physician explain that to you? And
He did.
okay, and you're agreeable to have that done?
Yes.
Did you have any other questions about it?
No.
Okay, I'm going to be bringing in a consent for you to sign to have that procedure done. And also this evening we're going to begin in on your pre-procedure checklist.
Okay.
Okay? And I want to review the medications that you told the emergency room nurse that you're taking, just to make sure we have everything clear. I see that you take Toprol 50 milligrams twice a day, and that would be for your blood pressure. You also take Prenavil 10 milligrams once a day for blood pressure. Now, why do you take the Zantac? I didn't see anything in your history that indicated why you would be taking Zantac.
I had to start taking that when I developed a bleeding ulcer from taking too much ibuprofen.
Okay, so you know what, that's important for us to know in your history. I'm just going to go in here and modify and add some information. Now, anytime a patient is in the hospital, they're at risk for developing a blood clot. Reason could be because of lack of movement or just other situations that could occur. So we like to do what's called a VTE prophylaxis because we'd like to help to prevent that. So I remember you saying, you know, one of the things we do to help prevent blood clots is that we give patients an injection of heparin. Now, I recall you saying a moment ago that you'd been told before that you have an allergy to heparin.
Yes.
What happened when you had heparin? Did you break out in a rash?
Yes, I did. I had bumps all over.
Really? And did you ever hear the term thrombocytopenia?
Oh, maybe.
Okay, because that is usually what we see. It's called heparin-induced thrombocytopenia. And we have some information on it right here in the computer. I could print it for you, but I also have somewhere else I could go to print something a little bit more patient-friendly. But basically, it just explains how thrombocytopenia occurs. You know, heparin is a blood thinner. Because it's a blood thinner, it kind of affects your platelets. So let's put that in your allerg or check to see here. Because of that, we'll be excluding you from this, and the physician will find something else to do for you to help with preventing blood clots.
Okay.
And if we go back to our intervention list, it's going to give me a reminder when we're all done here to make sure that I input that allergy for you. And the last thing I'd like to do is just review your care plan. We have a plan of care while you're here, and it's going to talk about pain as well as glycemic control because of the diabetes. So I'm going to leave this up here for a moment so that we can take some time to review it together.
Okay.
Okay?
Okay, so thank you Cheryl and Sean for giving us that example or that patient scenario. Now what I want to do is go through some of the informatics concepts that you saw in the scenario and point those out to you so that you understand what they were doing. Decision support example for VTE. What a decision support sort of guides the user as they're caring for the patient to make the correct decisions. It sort of helps you so you don't have to rely on memory any longer. You have technology to use as your tool. So that as Cheryl was going through, this is the VTE prophylaxis assessment that is done on every patient at our hospital. And it's becoming a national patient safety goal, and as well as to qualify for meaningful use, we must assess each patient for VTE prophylaxis. What we did when we created this form, VTE prophylaxis admission assessment. Each patient when they come into the hospital has to be assessed for VTE, as at risk for VTE. So based on what the nurse documents here, this side of the form has all the exclusion criteria. This side of the form is things that we already have covered in a post-op care set, and so this just goes into a black hole or whatever. And if you notice here, if the patient is an active bleeding patient, they would check that and they would be done with the form. If you see the patient has an INR greater than 2, that displays in the section here. And the patient would be clicked, we would click yes, and the patient would not get any heparin or VTE prophylaxis. Same with the platelets. If the platelets are less than 50,000, those results display here. If the patient is already on heparin, that medication profile is listed here, and it shows the list of medications that the patient is on. And the reference text, the VTE reference text, if you saw it in the scenario, Cheryl right-clicked in the reference text and she saw two things. One was how to complete this form. So if there's a new nurse or somebody who hasn't done it in a while and they don't understand how this form works, just by right-clicking over here, there's a little PowerPoint that's built in to show them how to complete it. And the other thing that was in there was what is heparin-induced thrombocytopenia. And it tells the nurse, maybe it's a new graduate, sort of closes that gap between a new nurse and an expert nurse, telling them what heparin-induced thrombocytopenia is. So that is one example of decision support, is our VTE prophylaxis assessment. And this shows behind the evidence base on that form. This talks about the VTE and the heparin that I just explained. We also had in the scenario a reminder to provide imperative data. You saw that several times when Cheryl was on the intervention list. These are things that help the nurse to organize their day, organize their time. The nurse has so many things coming at them in a 12-hour and 8-hour day that it's sometimes really hard to remember everything. So these are timed and dated, and many times you can see the last time it was done, so that you only need to go to one place to find out what is due for that patient. It's very important when you're designing an electronic medical record not to inundate the nurse with these reminders, because it could become an unmanageable list and then the nurse doesn't want to even look at it. So what we have to do is strategically place these reminders to the nurses, and we ask for their feedback and we have them help us design which reminders they want to go here. And it reminds her to add the heparin allergy because she clicked the patient had an allergy to heparin from the VTE prophylaxis. That patient should never get heparin. It's a safety mechanism. Now the nurse is reminded because they weren't in the allergy section. If the nurse clicks on this, it takes them right to the allergy section so that she can add that straight from here. She doesn't have to go find it in the chart. The pre-procedure checklist is loaded here. And again, smoking cessation education, because the patient said that she was a former smoker, that patient has to have smoking cessation education, so that when that identified learner is there and the patient is there and they're ready to learn, the nurse can then pull up this intervention list, click right here, and after she's done teaching, document the patient's response to that education. For data mining, there's a couple other things. There's multiple ways you can data mine. These are just a couple examples. The nurses have something called a PAL, a patient access list, in their computerized documentation system. Most software companies have similar things. It's just how do they use it and how do they display it. But once you understand the informatics concepts, you can use almost any software in the same way. So for this type of software, we have a column here that we loaded at our hospital for our nurses because they wanted easy access to the H&P on a patient, so that when they're getting a report or when they're getting a new patient, it's a very easy way to get to that information. So we were able to display a history and physical column here, and when they click that, they get the history and physical for the patient. Another way to use data mining is when you're in the lab results section and you're looking up the labs, there is a way to trend these. There's a way to graph them, there's a way to trend them, and it gives you multiple different options to how to view that information. Not everybody likes to view it in the same way, and so there's different options for you to view that, and that's another example of data mining. If you noticed in the simulation scenario, it was very easy for Cheryl to see when the last time the patient received that pain medication. She simply went to the EMR summary and she could tell that earlier in the day the patient received Dilaudid 1 milligram. Before the computerized electronic medical record, we had to go and find the paper MAR, or in this case, rely on the report we received from the emergency department and maybe potentially go call them to find out when the patient received the last pain medication. This again provides information to the caregiver at the time that it is needed. Very important. So it's not what we're putting into the computer, it's how we're taking it out and using it to make these decisions quickly for our patient. When Cheryl asked the patient who their identified learner was, we don't want to teach not the wrong person, but we want to maximize the time we have with our patients. So we collect this information when the patient is admitted, and we ask them who takes care of certain things while they're at home, because we want to make sure that we have the right person when we are spending our valuable nursing or therapy or clinical team time. It has to be with the person who is going to be able to learn that information. So we display the learner on our plan of care, or this used to be called a Cardex, and it tells us, this is another example of data mining, because we can see right from here who their physicians are, which care plans we have on that patient, who the identified learner, and so on. It's a very quick way to get to this information. And our nurses were very instrumental in telling us what they wanted to see here. So when you have they wanted to see the physician's phone number because they needed a quick, easy way to get to the phone number. And so we loaded that onto our plan of care. Again, another example of data mining. When we are doing handoff communication, we like the S-bar, and I think that a lot of nurses like the S-bar format. There's a way to strategically pull data that we have inputted into the record and display it in an S-bar format, so that when the nurse is communicating with another nurse, with a physician, or with any other part of the care team, that data that has to do with the situation is all in one spot. And so you could go through this nursing S-bar view and see the information that you need when you want to give that report or talk about the patient. So you see many ways that we can use the computer as a tool to facilitate care of the patient. When we develop our care plans, our interdisciplinary care plans, we have to start focusing on what does the patient need to not come back into the hospital. There are so many things that we put on the patient's record to try to teach them, and they're very unrealistic. What I would like to see happen is that the nurse is the one who is the quarterback of the care team. The nurse is the one who is with the patient, deciding what that patient needs to know. Then everyone else who's touching that patient or caring for that patient should be able to focus on those same goals. So I see the interdisciplinary care plan as a tool to help the nurse and the team teach the patient a very focused items that would help them stay healthy and out of the hospital. In the example that we had in the scenario, the patient was a diabetic, a new diabetic. It would be impossible to teach the patient all the options that we have in the computer for diabetes. What we need to do is focus our time with that patient while we have them on something that would keep them out of the hospital. For example, how to treat a low blood sugar or a high blood sugar. Let's take the low blood sugar. The patient everybody has taught the patient how to manage their blood sugar and their diet. The patient is much less likely to come into the hospital with the low blood sugar. The patient is at home and can treat it. Anyone who comes in contact with that patient, knowing that goal, can have a conversation or can arrange for the identified learner to teach about how to manage that blood glucose. This includes the case manager, the nurse, especially the nurse, the case manager, any respiratory therapist, a physical therapist if they happen to be in there, certainly the dietitian. The entire team should focus their teaching on a few things. And then when the patient goes home, we need to continue that teaching and set that up for the patient to complete the loop so that the patient learns about their diabetes and is much more able to stay at home and have that treatment successfully at home, and then they won't come back into the hospital. And that concludes my presentation for using technology to care through a new lens. I hope you enjoyed it, and I hope you find at least some ways to incorporate some informatics concepts into your teaching at your nursing education site. Thanks for your time.